We're just going to set this off by asking some of the theme leaders just to say a little bit about their theme. So this is a taster for what's going to happen over the next 90 minutes.
I'll start with a quote from William James Mayo, who wrote in 1928, "The ideal of medicine is to eliminate the need of a physician. And we cannot achieve that by sitting in our ivory towers and clinics. What we've got to do is go out into the community and work with everybody to achieve that." And obviously, from my perspective as a pediatrician, I believe the earlier we get in, the better the outcomes long term. And that is the focus of our theme. And we're concentrating for the moment on 3 areas: on allergy, which is immensely common, and improving care pathways; on sickle cell disease, because that is a problem that we see mostly around London and in northwest London, to again improve care and to address the problems that the patients have; and finally to try and reduce the demand on accident and emergency, which of course is very topical at the moment. We are linking very closely with public patient involvement, and I'll just highlight one thing. We have a 14-year-old boy who is developing an app for us to deal with allergy and asthma, and it's from the patient's perspective. He is a patient with asthma and allergy. He happens to be an incredible IT expert, and he's developing the app for us. And the other thing is to highlight a large number of NIHR grants that have come in attached to the work that we're doing, particularly related to the mental health theme. So we have a reader in child and adolescent psychiatry who's looking at intervening in pregnancy to deal with pregnancy-associated anxiety. And the key for us is that that will, we believe, have a big impact on the children subsequently.
Yeah, so we have 3 projects within the breathlessness theme, looking at reliable care for heart failure, reliable care for COPD in primary care, and a joint rehabilitation scheme. I'm going to concentrate on one of those, the heart failure project. What we're doing with heart failure is trying to give more reliable care to patients when they come into hospital with heart failure. And we're gifted in heart failure in that it used to be a much worse disease than it is now, because we have a lot of treatments that we can give people, and we've got a lot of evidence that tells us that those treatments are incredibly effective at lengthening life and reducing symptoms, reducing readmissions. But what we see, and it's not just here, and it's not just in northwest London or all of the UK, but it's in other countries as well, it's in the United States, it's in Europe, is that when people come in with a complex condition, and for instance they need 5 things to make them better, each of those things they don't always get. And in fact, they only get around about 60-ish% of the time. And the problem there becomes that if you need 5 things and you only get each one 60% of the time, the number of patients who get all of them is actually very, very small. And this is a really common problem in healthcare. And it might seem easy to fix, but it's not. It's really challenging, because there are probably about 200-300 people who could potentially deal with that patient. They'll be on one of probably 5 to 10 different wards. They'll be in an admission that's got different stages. And really, each of those interventions relies on people remembering at some point to do them. So our project is around making sure that people get all of the interventions that they need. A really challenging problem in healthcare improvement, because we don't have the command and control just to tell people to do that. It's a bit more crowd control. With so many, it's herding cats, the sort of cliche. So that's what we're trying to do, and that's what I think we will do at Northwick Park.
First of all, start with an apology, because the term frailty is a medical term, and we know from the work that we did around co-design, co-production, that's a terminology that many patients and carers don't like. So there's an element of us using a term that works in the medical literature, but actually we need to think about what is the term that's more effective or more appropriate in a patient environment. But the theme that we developed is around looking at frailty in several dimensions, both physical health, mental health, or psychological well-being, the social and economic factors, and also the physical environment. Now, when we started looking at that, We didn't think that was very novel. We thought everybody must have done this before, but actually when you go to the literature, there isn't as much around the concept of looking at all of these 4 domains. There's probably one other paper. And John Soong, one of our PhD students, did a lot of work using hospital data to actually verify that this model has some validity. And so the frailty assessment component is how do we develop a system where we can develop a common language, a common communication that crosses professional boundaries and crosses organisational boundaries, and also accepts that individuals may not be frail all the time. They may move in and out of frailty. So the concept that frailty, still using that term, could be dynamic, and therefore there are potential interventions, is something that we wish to get over. And so that's work that we're starting. We've looked at some simple scores of the first 120 patients using an app that we've developed with Tim Taylor and others. So the results of that will be available within the next few weeks. And where that links is to how it links to medication, which Vanessa will pick up on a moment, because the medication often tells us something around the patient, both physically, mentally, and where they're living.
So we're optimising medicines in frail patients, hopefully, and that involves doing what we do very well at Chelsea and Westminster already, but to just give you a brief summary of what we've done so far in the medicines optimisation theme. We've been out on the road and we've tried to engage stakeholders, other hospitals, other departments that would like to join in with us. We now have a core intervention, which is reviewing and stopping medicines that are found to be inappropriate in the elderly population. And we've got a name, REMAC, which is reviewing medicines in acute care. So that's what we've done so far. We're clear about what we're going to measure now and how that will show improvement. And the team have been gathering background information and to inform our research. We're checking that we've embedded and sustained what we already did in CLAHRC 1, which is about medicines reconciliation under the medicines management umbrella. We've written up some cases for publication, and we have a Stop It in Outpatients paper due to be published in Geriatric Medicine. We define the levels of medicines reconciliation, and we've checked our standards remain high so long as it is patient-led. This is going to be on a poster for the Quality and Safety in Healthcare Conference in April. We've surveyed junior doctors to find that they lack confidence in stopping medicines, even though they're quite gung-ho at prescribing medicines. Especially when GPs or other more senior doctors have started medicines, they have some reticence. So we're going to do some work with that. We're designing a bottom-up approach, and to this end, we're engaging with medical schools and with pharmacy educators to try and get better prescribing and de-prescribing practice taught to our junior doctors and pharmacists.
What we'd like to share with you today is our e-learning package, which we're developing within CLAHRC, and we're developing a series of modules based on our systematic approach to quality improvement, which we hope will both support our project teams, our fellows, and anyone else working across North West London and beyond in quality improvement in healthcare. So particularly today, we're trialling 2 of those modules, our module on patient and public engagement and involvement, and also our process mapping module. So I'd be very grateful if you could come over to the table today and have a look at these modules and tell us what you think. They're still in a development stage, so we'd really appreciate all your feedback. And if you are happy or willing to be involved with that process going on and testing some of our other modules, you can leave your details and we can get you involved in that process.
The public health and information intelligence theme is here to ensure that the delivery themes and the CLAHRC programme as a whole have the data that we need to do 3 things. To ensure that the work is focused on the needs of the population, to drive that work to success, and then to make sure that that success is effectively communicated and spread to other settings. And we're primarily doing that through 3 avenues of activity. One is around direct support for the delivery theme projects, and you'll see us out and about in the sector meeting with colleagues in information analysis teams and working with them to ensure that we've got the data. in running capability and capacity development activities. So, for example, the information analyst workshops that we announced at the last CL event and that have now been completed and are successful, and we're rerunning those this year in the near future. And then finally, we also conduct research to across large data sets, including public health data sets and including hospital episode statistics, to inform the development of the program. And so we hope that we are here helping the delivery themes to get that success that we all need. And so what I would ask from others in the room is come and talk to us, ask us questions, show us your data, tell us what you're thinking, and hopefully we can work together to bridge those boundaries that today is all about, and to get some collaborative success in our work.
Great, thank you very much, Fiona. So I'll keep it brief, but just to, I suppose, pick up on a couple of things that have already been said from Aidan and from John Warner, that patients are critical to our success. Everything we do is about them, and it's about how within this theme we strengthen the way that we involve them in this programme and in the work that you do. So those people who were with us in November will remember that we were talking about something called the Exchange Network, which builds on a lot of the work that we've done with people in the last 5 years, and in particular with our fellows. There are people in the audience who have helped us to get to this stage, and that's captured in one of our posters here. So the issue for today is we're now moving into a testing phase. So we use our quality improvement methods to strengthen our involvement. And what we want to do today is to test our membership form in the Exchange Network, and importantly, something called a skills audit. So John mentioned about the person in his team who's helping to build the app. Sometimes we don't take enough time to work out what people actually are interested in and are capable of doing. So one of the ways we want to do that is by helping people to do that at the start of their journey with involvement. So I would encourage you today to come and talk with me and with others in the room. Come to the workshops this afternoon and be part of a plan, do, study, act cycle. We're going to do the do and the study this afternoon. And I also going to very quickly promote a DVD that one of our former fellows has done, and with people in the room, about living with oxygen. So if people get a chance to have a look at that, it very much tells a patient story. There's no professionals involved. The story is very compelling. So have a look at that. And there's also some new standards that have recently been published about involvement as well. So get the updated news from me on PPI.
Yeah, so the improvement science theme is about the methodological approach, the use of methods to help you get evidence into practice, such as action effect diagrams, PDSA cycles, etc. Today, I just wanted to talk quickly about the planning for long-term success. I'm sure many of you would have been aware that we've been developing a tool to promote long-term success. The idea is to give a method to enable you to think about what it is that will promote long-term success, and not have your implementation, your intervention disappear, I guess, at the end of the funding period. So the idea of the tool is to prompt you to think about aspects that are influential in long-term success, to gather the views of the team collectively, to produce some data, and for that, most importantly, to encourage some discussion and then to prompt action. So we've had, and this is very much a work in progress, this is a bit of an experiment. We're trying to develop this over this round of projects, and I know many of you have had an initial stab at this, so we do have some data from some of these projects. So I'd be really keen, if you've used it and you want to come and talk to me about it, if you see strengths, if you see weaknesses, please come and chat to us. If you're not familiar with this, I'm very happy to talk you through the process of how it was put together.
I think I've said a number of times before that the mental and physical well-being theme is a cross-cutting theme, but we also have a delivery aspect as well. In terms of being a cross-cutting theme, what we're here to do is we're here to think about how mental and physical well-being theme can support everything else that goes on within quality improvement within CLAHRC. We are looking at this and talking to a lot of people, and the event the workshop this afternoon and the event in April will be broadening out that conversation and be inviting all of you to join in and participate with that and help us create this. And the three themes that we're working around, thoughts that we're working around at the moment are, what do we mean when we talk about well-being? What do the words holistic mean and integrated care mean? Let's have a conversation about that. What's the scope of the theme? How wide or how focused should it be? And probably most importantly, what is the impact around quality improvement? What does mental and physical well-being have to offer in terms of supporting quality improvement projects and programs? And how do we do this? What are the practical things around this? And what are the research questions that we want to answer in improvement science? Moving on to the delivery side of our work, we have been working really hard. We've got a huge work stream around working around what we're calling our big data project in increasing access to talking therapies. We have the agreement of CNWL and West London Mental Health Trust to share their CBT talking therapies databases with us, which gives us, somebody called this a gold mine of intelligence about how talking therapies and CBT could support people with long-term conditions. What are the things, what are the service models that indicate that will support people's recovery in terms of common mental health problems? We have already started collecting the data on that. I'm delighted that we've got a PhD student and we're in the middle of the recruitment process for that. And we're hoping that person will start, the successful person will start in April. And we've also developed links with Manchester CLAHRC, and we're looking to work with them more on that. So we're really delighted on that. And we also have the another one of our work streams that we want to highlight is the SHINE project, which is in partnership with CNWL and funded by the Health Foundation. And if I may, I'll hand over to my colleague Bill.
Thanks, Liz. So I'm Bill Tiplade. I'm a consultant clinical psychologist working for Central and North West London Foundation Trust, CNWL. And we've been delighted to be able to make a partnership with Liz and with CLAHRC to support the work that we're doing, which is funded by the Health Foundation as part of their SHINE fund to kind of give some seed money to support kind of innovative service developments. And we've been working on something which really brings together physical and mental well-being. As people might be aware, there's a very large kind of mortality gap for people who experience severe and ongoing mental health problems. People are dying 15 to 20 years younger than the general population. I mean, this is, in fact, a kind of modern-day scandal that's happening in our midst. And whilst we don't suppose we will solve that here and then, our work is very much driven by that need. We've been looking at the extent to which in kind of mental health care services people are getting kind of routine physical health assessments and whether those assessments are leading on to the sorts of interventions that should be provided. We've got lots of evidence, lots of tools to guide us in that, but the reality is that many mental health trusts around the country, and CNWL is no exception to that, are not very good at doing these simple things well in routine practice. So that's really been the aim of the work we've been doing. We've been doing that across a mental health ward, Danube ward at St Charles Hospital. It's great to have service user and staff colleagues from the project here with us today. And we've been kind of mapping in some detail using CLAHRC tools, some of the processes that go into assessing people's physical health and finding some of the ways in which those are tangled or don't work very well or have various different people trying to do the same job at the same time. And we've really worked hard on getting together the MDT, and I think a really wide MDT engagement has been critical to the work we've been doing to really get people together and look at making something that's much more streamlined and works better. And the initial feedback we've had from PDSAs is that actually nurses and doctors on the ward have said actually this is easier to use, this is a simpler system. So we're really, really pleased with that, and our service user colleagues are saying this is an assessment that would be better to go through actually. This feels more human. I think the other thing to flag up is the work that we have been doing with service user project team members, and we've really worked hard to make this a co-produced project between those of us with professional expertise and people who come with their own experience of using mental health services. We've developed a physical health passport, which has actually been led by our service user colleagues, and we're delighted to have been able to share the work in that way. So we're now going into a kind of testing phase, implementing our intervention, and we're optimistic we're going to demonstrate that we've got something which has the potential to change practice and be rolled out across our trust and hopefully wider than that.